What does the name gluconeogenesis mean? It simply means making new glucose. Gluconeogenesis, which is shown here, is basically glycolysis in reverse. Gluconeogenesis is primarily found in the liver, because when the body is low on blood sugar, the liver can use gluconeogenesis to pump out more usable glucose. This way, the body remains in a euglycemic state, even during fasting. Where else is gluconeogenesis performed? Well, the kidney, also in the intestinal epithelium. The pathway begins with pyruvate and ends with glucose, and uses most of these enzymes. However, there are 3 irreversible steps in glycolysis. The body uses 4 unique enzymes to bypass these 3 irreversible steps. Before we look at these 4 enzymes, do you remember what cofactor is required for carboxylase enzymes? Hopefully you're thinking biotin. The first key enzyme of gluconeogenesis is pyruvate carboxylase, which converts pyruvate to oxaloacetate. This occurs in the mitochondria, requires biotin and ATP, and is activated when there is a high concentration of acetyl-CoA, since this means you don't need to be producing more acetyl-CoA and ATP, and would be better off storing energy as glucose in glycogen. Next, phosphoenol pyruvate carboxykinase, or PEP carboxykinase, converts oxaloacetate to phosphoenol pyruvate, or PEP, in the cytosol. This uses GTP as a source of the phosphate. Fructose 1,6-bisphosphatase is the third irreversible enzyme, which converts fructose 1,6-bisphosphate to fructose 6-phosphate. And finally, glucose 6-phosphatase removes the phosphate from glucose 6-phosphate to form glucose, which is then free to be released into the bloodstream and used by the body. This last step occurs mainly in the hepatic endoplasmic reticulum and does not occur in muscle, since muscle lacks this enzyme. Think about muscles as kind of selfish entities, and the liver as kind of the patron saint of the body, willing to release metabolites for the good of the rest of the cells in the body. Glucose 6-phosphatase is also the enzyme that's mutated in von Gierke disease, which we'll talk about soon. So, in summary, gluconeogenesis occurs mainly in the liver and creates glucose from glycolysis, fatty acids, or TCA cycle intermediates. It should come as no surprise that a deficiency in one of these 4 gluconeogenic enzymes can cause hypoglycemia. On test day, how in the world can you remember the irreversible enzymes of gluconeogenesis? Just remember that gluconeogenesis is a pathway that produces fresh glucose. The P stands for pyruvate carboxykinase, the second P stands for phosphoenol pyruvate carboxykinase, the F stands for fructose 1,6-bisphosphatase, and the G stands for glucose 6-phosphatase. How else can we make glucose molecules? Here, we see the TCA cycle. Odd-chain fatty acids can serve as glucose sources, since they yield propionyl-CoA, which can enter the TCA cycle as succinyl-CoA. Even-chain fatty acids, however, cannot be used as glucose sources, since they can only be broken down into acetyl-CoA, which disappears as CO2 by the time it reaches oxaloacetate. The hexose monophosphate shunt, also called the pentose monophosphate pathway, is shown here. This takes place in the cytoplasm of the cell. Its purpose is to synthesize NADPH and ribose sugars when glucose 6-phosphate is abundantly available. The HMP shunt can be broken down into 2 general steps: an oxidative, irreversible step, and a non-oxidative, reversible step. In the irreversible oxidative phase, the first molecule of NADPH is produced by the first enzyme, glucose 6-phosphate dehydrogenase, and another is produced later on. Do you remember what NADPH is used for in the body? The NADPH can be used in reductive and anabolic reactions, such as in glutathione reduction in red blood cells and cholesterol synthesis in the liver, which is why this pathway is most active in lactating mammary glands, the liver, adrenal cortex, and erythrocytes. If the cell already has plenty of NADPH, this pathway will be shut down since NADPH inhibits the rate-limiting step, G6PD. The pathway also consists of a non-oxidative reversible phase. The irreversible steps created the NADPH, but the reversible non-oxidative steps will create ribose 5-phosphate derivatives using phosphopentose isomerase and transketolases. You don't need to know which ones specifically, just transketolases is fine. These ribose derivatives can be used elsewhere in the body, such as for nucleic acid synthesis. The transketolases require vitamin B1 and are often used to test for B1 deficiency. Notice how the end products of the HMP shunt feed back into the glycolysis pathway. This way, the body can use the HMP shunt to make NADPH or ribose derivatives without creating much waste. So flash quiz time. A 2-year-old girl is born with a glucose 6-phosphate dehydrogenase deficiency. This interferes with which step of the HMP shunt? Well, this disrupts the irreversible oxidative phase, or the first reaction of the HMP shunt, which converts glucose 6-phosphate into CO2, 2-NADPH, and hydronium ions, and a ribulose 2-phosphate molecule. We just talked about the HMP shunt. What's the important function of the irreversible oxidative reaction of the HMP shunt? It makes NADPH. The enzyme, glucose 6-phosphate dehydrogenase, is involved in both the HMP shunt and the respiratory burst. It plays a key role in regenerating NADPH. Let's say that we have a substance that is harmful to the body, like hydrogen peroxide. It can cause oxidative damage to the body if it's not dealt with. So what will our body do to protect itself? The body will use a reduced form of glutathione to neutralize the hydrogen peroxide and turn that into water. However, to keep high supplies of reduced glutathione available, the body needs lots of NADPH. Not NADH, NADPH. Where did I say we got most of our NADPH? Well, that's the HMP shunt, right? If we're missing the key enzyme glucose 6-phosphate dehydrogenase of the HMP shunt, we can't make enough NADPH, and our body is at risk of experiencing excess oxidative stress. What's this? An almost guaranteed test question. Yeah, that's right. The boards love this enzyme, so I'd pay close attention if I were you, at least for the next few minutes. Well, G6PD deficiency is actually the most common human enzyme defect, and it's X-linked recessive. One of the main problems in G6PD deficiency is the inability to reduce glutathione, which makes cells much more susceptible to oxidative stress. Under normal conditions, most patients with G6PD deficiency might not have any symptoms, but when subjected to oxidative stress due to things like inflammation or exposure to certain drugs, like sulfonamides, permaquine, and isoniazid, their red blood cells can't handle it and will lyse, causing hemolytic anemia. These patients should also avoid fava beans, since they contain high levels of oxidants. On test day, make sure you focus on the information provided. If the question depicts a black individual who is taking a new medicine and develops hemolytic anemia, you should immediately think of G6PD deficiency. With so many negative side effects with G6PD deficiency, are there any positives to having this disease? Well, the only silver lining here is that G6PD deficiency provides some resistance to malaria. Actually, possibly because of the higher oxidative stress experienced by the erythrocytes. Remember where the parasite lives? Well, it lives in the blood, so if the blood is lysing a little bit more than normal, it kind of makes sense that the malarial parasite would not have a home. How else could you be tested on G6PD deficiency? One way that the boards like to present this is by showing you a slide depicting bite cells. Bite cells, which are indicative of G6PD deficiency, are RBCs that have bites taken out. Why the heck would phagocytes bite off parts of RBCs? Well, in normal individuals, the NADPH serves a protective antioxidant role to the RBCs. If you're not able to reduce NADPH because of a G6PD deficiency, you aren't able to regenerate the reduced form of glutathione, which protects the cell from hydrogen peroxide damage. When you can't protect the cell, you get denatured hemoglobin that precipitates within the cell. This denatured hemoglobin is called a Heinz body, and these occur during times of stress. Phagocytes recognize these Heinz bodies in the RBCs and bite off pieces of the cell, trying to get rid of these Heinz body accumulations. If you see Heinz bodies or bite cells on test day, immediately think of G6PD and or NADPH deficiency, although other disorders like thalassemias and asplenia may cause patients to also exhibit Heinz bodies, and so these disorders should also be on your differential diagnosis. So how does fructose, a monosaccharide, fit into carbohydrate metabolism? Well, fructose metabolism is important because it gets converted into a substrate for glycolysis and energy production. As you can see, fructose enters the glycolysis pathway at glyceraldehyde 3-phosphate. Normally, it's converted to fructose 1-phosphate by fructokinase in the liver. The enzyme aldolase B then converts fructose 1-phosphate to dihydroxyacetone phosphate and glyceraldehyde. The enzyme triose kinase can then combine glyceraldehyde and ATP to make glyceraldehyde 3-phosphate, which is one of the substrates in glycolysis. Now, this is in a normal, healthy patient. What happens when you're missing key enzymes in this pathway? Essential fructosuria is an autosomal recessive defect in fructokinase. If you're missing fructokinase, what happens? Well, fructokinase is the enzyme that phosphorylates fructose after it enters a cell, and it's this phosphorylation that prevents the fructose from crossing the cell membrane and leaving the cell. Therefore, without this enzyme, there's nothing keeping fructose in the cell, so it just washes out in the urine. Well, big whoop. Thankfully, this is a benign and asymptomatic condition. Will you see large amounts of glucose on urine dipstick in patients with essential fructosuria? No, because the urine dipstick is sensitive for glucose only. However, fructose intolerance is a more serious autosomal recessive disorder of the enzyme aldolase B. Without aldolase B, fructose 1-phosphate accumulates, and since it's already phosphorylated, it can't leave the cell. This consumes a lot of available phosphate, which inhibits glycogenolysis and gluconeogenesis, two processes that require large amounts of phosphate to operate. Without glycogenolysis, the breakdown of stored glucose, or gluconeogenesis, the formation of new glucose, fructose intolerance causes hypoglycemia, or in other words, low blood glucose levels. You'll usually notice symptoms of fructose intolerance after the consumption of fruit, juice, or honey. How do you think the dipstick will look in these patients? Well, in fructose intolerance, patients will have detectable amounts of reducing sugars in the urine, but the sugars are again not glucose. Sounds silly, but hey, I'm emphasizing it for a point. So again, the urine dipstick will turn up as negative. In addition to hypoglycemia, patients might also have jaundice, cirrhosis, and vomiting due to the toxic accumulation of fructose 1-phosphate in the liver. The treatment for this is to not eat fructose or sucrose, since fructose is a disaccharide composed of fructose and glucose. In general, disorders of galactose metabolism, which we'll discuss next, are more serious. So, flash quiz time. Is essential fructosuria or fructose intolerance more symptomatic? And if so, why? Well, fructose intolerance is worse, since the deficiency in aldolase B leads to fructose 1-phosphate accumulating in the cell, reducing available phosphate stores. So, remember, this inhibits both glycogenolysis and gluconeogenesis, leading to hypoglycemia.